Toni Lawson, how are you?
I'm great.
I'm great. You look great. Thank you for coming. This conversation has been a long time in the coming.
Yeah, it's been a little busy lately.
A little busy. You are the government affairs liaison for the Idaho Hospital Association, correct?
Correct.
Fantastic. So you, in effect, represent a lot of hospital interests and hospital concerns to the state legislature and governing bodies in the state of Idaho. Yeah?
Yeah, we represent every single full-service community hospital in the state of Idaho. So from the smallest little facility in Cascade to, St. Luke, St. Al's, Kootenai.
God bless it.
Everywhere in between.
Look, there's been a big conversation around medical access in Idaho, which has so many different facets and so many different issues, ranging from medical education in K through 12, or medical interest and even possibility, people believing that they can become medical professionals, all the way to state legislation, all the way to reimbursement rates and Medicare and Medicaid, and there are all kinds of problems, right? But one thing that came up recently in a court case, and then people started talking about former Representative Todd Achilles, because he's now...
Has he officially stepped down?
He has officially stepped down. He is disaffiliated with the Democratic Party. He's running as an independent for U.S. Senate against Senator Jim Risch. But he brought up non-competes, and non-competes kind of jumped onto everybody's radar because there was a snafu with St. Al's and a physician regarding a non-compete. Non-competes are big things in Idaho. They exist, and they are not. They do hold some weight. And I asked you to come on because some people have said, hey, non-competes are things that are actually keeping Idaho from having more physicians. And again, I don't know anything about it, but you do. So here you are. Help me understand non-competes.
Yeah, this is a fascinating kind of new happening. This has been an issue, particularly nationally. Like the Democrats in Congress, it's been an issue for them. Bernie Sanders has been beating this drum for a long time.
We shouldn't have non-competes.
So it's not a new topic nationally.
Sure.
But I mean, I'm at almost 20 years. Well, I'm 20 years in this field, over 20 years, almost 20 years with the Hospital Association. This has never been a topic that our members have brought to our attention, that's been contentious, that we've even really dealt with. And Representative Achilles brought this piece of legislation, and from what I understand in my conversations with him, it wasn't really aimed at the medical field or hospitals.
If you're flipping burgers, if you're delivering babies, he was like, listen, this is cross industry.
Yeah. So, the poster children for this were not hospitals and healthcare professionals. But then this case came forward at St. Al's, and it was just like the timing
just right.
was interesting. And so I actually had to do a lot of interviews and conversations with our members to say, how many of you are even using these? And it's really varied. It's varied around the state. It's varied in the type of non-competes that they use. And so it's not something consistent around the state. And the one thing I can say is we have a lot of conversations with hospital CEOs, recruitment experts.
Sure.
Not once have I ever heard them say, the reason people are telling us they don't want to come to Idaho is because of non-compete clauses in contracts. That's never come up as a reason people don't come here, and at least a stated reason.
Understood. And if I may ask, it's my understanding that St. Al's uses non-competes, and it's also my understanding that St. Luke's does not. And I'm sure you could tell me if they both have wonderful medical professionals. They both have people that, come from out of state or work for them. These are two gigantic hospital industries, hospital complexes. And it's like, okay, if having a non-compete created an environment where they couldn't get doctors, then like St. Al's theoretically wouldn't be in existence and wouldn't be in business. But like St. Al's functions, St. Luke's functions, they're both offering medical services, widespread medical services. So it's like, okay, apparently it doesn't deter people significantly enough that they don't work for St. Al's.
Yeah, they're different business models. They're different, and some hospitals employ physicians, some don't. Some hospitals, have kind of extensive clinics and specialty services, and some don't. So it's really varied throughout the state. And it is, people talk about the market. I actually think this is where the market actually dictates. If a hospital had non-compete clauses and they're consistently losing physicians or other professionals to other hospitals that don't, then they would probably reconsider whether or not to have non-compete clauses. I was talking with a little hospital CEO the other day and asking him, so tell me, what's your situation? He said, we have them. At the same time, if a physician pushes back on it and says that's, a decision they would make whether or not to come to our community, we'd take it out. And he said, and actually, when it all comes down to it, if we lose a physician to someone else in the community, as long as that physician's still in our community's better off for it. But this is a small rural hospital. And the key issue there was as long as that physician stays in our community. Now, if that physician now leaves after you've put all of this time and energy and investment into a practice for them, and they go to another community, but that's still close enough to compete with you, then you've lost that physician in your community. So it's not helping.
You've lost that investment.
Yeah.
And that correct me if I'm wrong, but that's the nature of the issue here, which is, look, if we invest in somebody, getting them going with a practice, we're feeding them patients, we, make the connections necessary to have a successful medical, clientele and be offering value. That takes time, that takes energy, and that's a resource that they give out. So they're like, hey, look, we can't get you set up, get you connected, get you working, doing all these things, and then have you 6 months in, turn around and just stick in my eye, and now you take all the benefit we gave you. So that's the nature of the motivation. Not that that's something that cross industry is always done. Some people do it and some don't. So some just have different ways of negotiating and navigating those risks, but that's why non-competes are utilized in some cases.
Yeah, and it's particularly important for a small rural hospital that wants to expand some kind of service. If they're going to, let's say they're going to open up some kind of specialty clinic or a radiology group, an off-site radiology that will help their community, but they have to put the investment into it. They have to do all these things. Well, they can't really just put all this investment and then lose that person and go, oh, well, we'll find someone else. I mean, the decision whether or not to invest those scarce resources into a specific area of practice or a specific service, they don't take those decisions lightly. Nobody does, but some have a little more wiggle room and leeway than others. And if you made the decision, you're barely scraping by, you're operating with minimal margin, you set something up, you recruit the person, you pay for a recruiter, that first, you set up the building, you do the advertising, you invest in the material, equipment, all of those things. And then that person comes in and 6 months later takes their patients.
Right.
That's just a much bigger impact for a small hospital than it is for a big one.
Gotcha. That makes sense. So bottom line is it is something, because we have competition within Idaho with hospitals trying to recruit doctors. We do have a healthy enough competition and a varied contract practice where, like, if you absolutely don't want non-competes, there's a hospital that will hire you. And if you don't care about the non-compete, then there is a hospital that will hire you as well. But we can let the medical professionals decide if it's worth it or not.
Yeah, I think this is when the market works. This is when we talk about being, market driven. This is kind of that example. And you should know, too, it's not just hospitals doing this. I mean, there are physician groups that do it. When they recruit a new physician into their physician group, they don't want them turning around and leaving. So it's not just hospitals. It's other entities.
And it's not just the medical field, obviously.
No,
right? Like if I had an architecture
This whole thing
firm,
was not around the medical field. When Representative Keeley started it, it's kind of that shifted. The focus has shifted to the medical field because of that one case. But it wasn't really about that. And given the environment in Idaho, our shortage of physicians, our shortage of healthcare professionals, if non-compete, if you're a physician and wants to come to Idaho and you think you can't practice here or you can't find a job because of non-competes, that's pretty unlikely. If this group has a non-compete and they're not willing to take it out of the contract, you got every hospital in the state looking for you to come there. It's not going to keep you from practicing in Idaho.
When we talk about hospitals across the state, there are a wide variety of issues. Some are rural hospitals, some are urban hospitals, some are catering to population groups that are, perhaps on Medicare because of age or different compensation rates, all kinds of different problems. But one thing that people focus on extensively is supporting rural hospitals. And there's a relationship between the rural hospitals and the urban hospitals that is actually not really understood, because the reason that rural hospitals exist in the current iteration is because they lean so heavily on the larger hospital systems for things outside of the standard like day-to-day operations. And that relationship has to stay really, really strong. That's what allows the rural hospitals to exist in their current iteration. Is that correct?
Yeah, and rural healthcare is a passion of mine. There's a reason I'm still in Idaho doing what I'm doing with the organization I'm doing it with. There's a lot more money to be had in some other areas, but it's because of this passion for rural health. And we always, everyone wants to protect rural hospitals. Everyone wants to protect rural health, and rightly so. We all are, everyone will stand up and say, yes, we want to protect rural hospitals. I think what people don't realize is every hospital in Idaho is a rural hospital to some extent. Every hospital in Idaho is treating patients from rural Idaho. Those patients, our small critical access hospitals, which is a hospital that's 25 beds or less, that has to be a certain number of miles from the next hospital, they have to meet a certain standard to be considered a critical access hospital. Their job is to take patients, stabilize and transfer. Stabilize and move them to a higher level of care. So every single large hospital in Idaho is treating patients from rural areas. And
generally the patients that have more tricky or higher risk issues.
Yeah, children's oncology services.
Sure.
St. Luke's is treating patients from all over the state and other states because of that specialty. You can't ignore, you can't disconnect our rural patients from our urban. And I always use urban a little bit, urban, because none of Idaho is super urban compared to some other states. But there is a connection there. And in a number of things, there are certain things, if you have a trauma designation, if you have a certain level of trauma designation, part of that designation requires you to give education and support to small rural hospitals. So you can't even be a large trauma center and not be connected to small rural hospitals in some way. Our cancer care, pediatric care, all of this specialized care, you can't get that in the small communities. They can't stand up those levels of care, those service lines. It's just financially impossible for them. And it's impossible because they don't have a volume of patients that you can afford to keep them up and running.
That volume problem was, I spoke with Brad Turpin from the Emmett, he's the CEO of the Emmett Hospital, and they had shut down their labor and delivery. And I had got a hold of him because at the time people were saying, hey, look, the legislation around, women's reproductive rights is shutting down a bunch of hospitals. And I got a hold of Brad and asked him, come on. He said, yeah, look, I'd be happy to come on and talk to you about this, but I can tell you right now that it's not just that. Like, yeah, maybe that had some effect, but the reality is we don't have the volume of the cost associated with labor and delivery is substantial. And he said, first off, if you're going to have labor and delivery, you have to have a 24-hour surgery center ready to go. And not just like kind of ready, it needs to be ready to go instantaneously. Yeah. You have to have all the supporting departments in place. And then you have to have people that are willing to work in that area, which I didn't really understand. I was like, well, of course, you're working in healthcare. It's like, no. Look, if you're a nurse and you want to be a labor and delivery nurse and all you want to do is bring babies into this world and that's what you want to do, awesome. It's like, yeah, that sounds awesome. You're like, right. You're not going to come work for us because, yeah, you might get to deliver a couple kids a day or one a day or one per shift. But when you're not delivering babies because we don't have the appropriate volume to keep you employed in this 40 hours a week, you're going to have to go do other things. So if you're a labor and delivery nurse and that's all you want to do, you're going to look to a larger hospital with a larger volume and you're going to ditch the Emmett Hospital, right? And he's like, so we have this gigantic cost around this with the supporting departments and centers. We have a difficulty staffing these positions. It's like, it just doesn't make sense anymore. And that's really unfortunate, but that's the way this goes. Like, we send our, patients elsewhere, and they have a drive. And if it's an emergency, that's a thing. But, other than that, they can plan accordingly, and hopefully you have enough time. But it's like, gosh, man, the considerations really are substantial when you're trying to weigh the lower volume of specialized care.
And that hospital sits in such an unusual market. They're a small rural critical access hospital, but they're not that far from Boise.
Right.
They're not that far from Caldwell. Now, when Caldwell shut down their labor and delivery services, that had a pretty significant impact, because that was one of the places they would refer patients to. But then you run into, another example of a small rural hospital in a really remote area. I was just there last week, and they had to put their labor and delivery kind of on pause. They didn't want to shut it down because they're in such a remote area that patients wouldn't have options. But they didn't have an OBGYN that could cover. And I was there, and I said, "How's that going there?" He was like, "We're so excited. We just, recruited this guy. He's here."
Got him.
And I was touring the hospital. He goes, "In fact, there's a labor going on right now. He's in there. We're so excited to have him." But then the next thing he said, "I have to hurry and find another one before we burn this guy out."
Yeah, right.
He said, right now he has no backup. There's no one to cover for him.
He's not taking a vacation.
Yeah.
He's not,
So his concern was, "We're so excited we have him. I have to hurry and find someone else so we don't lose him." So the pressure is still on right there to find another one. And it took a while to find the one willing to come to a remote area of Idaho. It was hard before, the abortion laws and those complications. Yeah, sure. It was hard to recruit to many areas of Idaho. And now for an OBGYN, it just makes it
that much
one
harder.
more thing.
One of the aspects of the difficulty of recruiting is that you have to, where the person finishes their residency has an incredible input on where they're actually going to stay. Because you have a really high probability. It's like, if I do my residency and finish my residency in like Louisiana, I'm probably going to stay in Louisiana. That's just probability what it is. Yeah, right. And therefore, people are trying to get residencies for more specialties. OBGYN, we don't have an OBGYN residency in the state of Idaho. Are there any large hospital systems, or large or small, that are trying to flush out, like, okay, how could we support getting this residency in place here so we can, for lack of a better word or term, home grow our own OBGYNs?
I don't know right now if they're actively looking at it. It's a huge expense. It takes, to have a residency program, it takes a lot of time from your existing staff.
Right. So that's what made me think of it. Because you have this OBGYN that's already stressed out, and they're like, well, hey,
help you
guess
train
what,
another
buddy?
one.
Now you get the benefit of
You
being
are
part
so
of this.
good.
You're going to train the future, buddy. It's going to be fantastic.
Even though we know you just got out 6 months ago, you just finished your residency program.
You haven't had a day off, and you're not going to get one, because now you get to teach.
So there are only a couple hospitals that could even consider it, that have the resources, that are in a location. We only have
the staff supply, the whole thing.
Yeah. And I don't know if they can make that pencil out. It's tough. I don't know if they can make it pencil out. And
has there been any discussion with the state to support those hospital systems, or it's like, hey guys, what we could really use is about $100,000 over there, so that we can get more of this thing that everybody knows we need?
Well, I haven't looked lately, but the last time I looked, there was a legislator who used to kind of like to nudge me once in a while and say, the hospitals really should be help paying for the residency programs, because they're the ones benefiting from them. So I had to go back and look at the numbers and say, Senator, actually, in Idaho, in this market, in the Treasure Valley, the hospitals actually put more into the residency programs than the state of Idaho. So we're doing our fair share right now. And he wasn't aware of that. I was like, St. Al's and St. Louis combined, their budget that goes into residency programs is larger than the state. budget that goes into residency programs. This has been a few years, so I can't say that that's the case right now. I would not confirm that. But at the time, it's just people are not aware how much the hospitals are putting into programs, nursing programs, residency programs, all kinds of things. And so I kind of had to get up and testify, and I felt kind of bad because it was a senator that we respect and work with well, but I was like, you don't have your facts straight. We are already.
You couldn't send him a text
giving.
Beforehand. You're like,
it
this
was
is
one
a
of
bad
those
idea.
things.
This is a bad idea. Don't do this.
That's what I always try. I never try to embarrass someone publicly or call them out publicly if I can help it. But sometimes things move so quickly that you don't have a choice, or the question just came up.
Right.
I was testifying on something else.
Don't ask about this. Oh my God.
And they asked me that question, and I had to answer. And afterwards, he's like, "Okay, Toni, that senator is no longer there." But he
no longer senator.
No longer a
he's
senator.
He's still with us. He's still alive.
He's great.
Great.
I saw him the other day. He's doing well.
Great.
He's no longer a senator.
Yeah.
But someone asked the question. Now I remember it was someone asked the question in committee. And someone was him, asked the question in committee, so I had to answer him, and I had to answer with the data that shows we already do that.
Right. So bottom line is that's a really difficult lift that has no real clear path forward at this point.
It's tough. And with what's happening, there were some programs, indirect medical education funding sources that could be used, and then those got cut. And then, it's always a question of, if you get cut over here, then that has an impact on what you're doing over here. And it may not have anything to do with that residency program, but if we just got, $100,000 cut in Medicaid or some other program, you got to make decisions, and you got to make tough choices. And particularly rural hospitals, you can't have a cut over here and not have it impact something else.
Speaking of cuts and tough decisions, I was just speaking with, I had Senator Cody Galloway on yesterday, and I also spoke with Senator Janie Ward Ankelking. She's going to come on in a couple weeks, both on JFAC. And JFAC made the call for the budget this year, obviously, as they do. And we are now experiencing I believe 4 to 6% budget holdback. Is that going to be affecting hospitals?
Well, I don't know exactly. I know the departments have been given the directive to find that savings. What we don't know yet is where they're finding the savings. So depending on where each department, if they do an across the board cut, or if they decide to eliminate a specific program, if they try to get, all of it kind of in one or two departments, or if they try to spread it across the agency, and we don't know yet what that looks like. So I don't know.
Gosh, what could it be? Let's say they just do a 4 to 6% across the board. What happens?
Well, they can't just cut reimbursement without the legislature approving that. So it isn't going to be just like, we're going to cut all you hospitals.
So
but
it's
what
not
happened
reimbursement.
a few years ago? Well, it could be, but some years ago they were short at the end of the year, and they just didn't pay folks for the last month until we got into July.
Oh my gosh, I had no idea. They can do that?
That has happened more than once in Idaho, that the agency ran out of money at the end of the year for different services, different things. And usually it's been, 2 weeks, or it's just right at the end of the fiscal year. They cut it so close.
Sure.
And, legally, if they don't have that money, they
can't spend it.
Can't spend it. And
what's
the
agency that does the reimbursement for hospitals?
Well, it depends on reimbursement for what.
Oh, gotcha. Yeah.
The Medicaid program goes through the Idaho Department of Health and Welfare. So
gotcha.
That would be the biggest one. Medicare comes from
Alex
the feds.
Adams. Come on. He's got to find
still
that
here.
4 to 6%. Yeah, right. But I hear the confirmations are taking years. So he may not.
That, functionality of the U.S. Congress is not working in his favor right now.
Yeah. Well, I don't think it's working in anybody's favor. That's just me. I shouldn't say that. Isn't it always a case that Congress has like a 9% approval rating? Isn't it always like nobody's happy with it?
It's one of those great things that everyone hates Congress, but they like their own guy. And so even when they have horrible approval ratings, that doesn't necessarily translate to pressure on your local guy.
Congressman Simpson and Fulcher aren't worried. Their approval ratings are high, but the same people that approve of them just hate the system in general. Well, that's fair enough.
And I probably shouldn't say that. We see that sometimes when people complain about hospitals. They're like, oh, hospitals. But then when you ask them about their hospital, like, we love our hospital.
Oh, my doctor's great.
Yeah.
Hospital's great.
Don't you, mess with my hospital.
Right. Well, I think that's the case with pretty much everyone. You see the same sentiment in public schools, right? People hate public school system in general, but they love their school. Don't cut my funding because my people are good.
Yeah. So,
it's who you interact with. So the bottom line is that it depends on the reimbursement, but it is possible that there could be a larger cut, a cut across the board, but it would have to, depending on what they cut, they would have to get.
We'll see them stop hiring, even though they've been approved to make hires. It wouldn't be uncommon to freeze all new hires, which in the Department of Health and Welfare would be really challenging because they had such a need to make some hires. That if they end up not doing that, that could slow progress of, House Bill 345 this last session, which was the most, significant Medicaid reform bill in Idaho in the last 20 years probably, had money in it to hire folks for the new managed care program that will be coming into place. Idaho is going to be moving to a comprehensive Medicaid managed care program. Well, if they decide to just freeze hires across the board, that's going to impact the folks that are supposed to be there taking care of that. So
too soon to tell.
Yeah.
Could be bad. Definitely nobody's going to be happy about
there will definitely nobody will be happy.
Yeah. As far as the Medicaid expansion reform from this last year, is there anything that really jumps out from a hospital standpoint that was good or bad? I know there was a lot involved.
There was a lot involved, and you can kind of pick apart different things. I think the big impact for hospitals here, aside from just if folks end up losing their eligibility to Medicaid, that impacts everyone, but particularly hospitals because they end up then being
because you can't turn somebody away at the door if they're going to have less preventative care, which means they're going to come in for catastrophic things. And if they don't have insurance, then the bills are going to be really high, which likely means you're going to be reimbursing or blah 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 blah.
So that always we are always concerned about levels of uninsured in Idaho, and that's. I think the big thing we're looking at right now that we are very concerned about is, so we decided to move forward with Medicaid managed care program. Part of that is a component that is called state-directed payments, which are federal dollars that allow you to supplement hospitals to help them make up for some of the losses that they take in caring for Medicaid patients. Because Medicaid pays less than cost. So there's a gap there. And for every patient we care for, we lose a little bit of money.
How much is that? Is it like 5%? Like if the bill's $100, you guys get like 95 and there's 5 back?
I think last time depending on who and what, taking all programs into effect, it ends up being like 56 or 60 cents on the dollar.
That you're not reimbursed?
That we're getting reimbursed 60 cents.
Oh my gosh. So you lose almost 50% of the bill.
And that's, then that's why you have these supplemental programs to help make up some of those losses. So we had that in place. We're going to move forward. We're going to have to work really hard to make sure that a managed care program doesn't negatively impact providers in Idaho. Typically providers aren't super excited about a big national healthcare insurance company coming in to manage the state, because typically that means they just take their cut off the top and then they start ratcheting down on all the providers. But we had the state directed payment program, which would maybe help make up for some of that. Well, the bill being, I don't know if it passed yet. I know it's
the big guy?
The big bill. Had limits on that program. and actually put a freeze on that program. So Idaho is one of the few states that did not have that program already up and running. So the legislature has approved it, but we haven't, that just happened this
you haven't
session.
initiated it, yeah.
So we haven't initiated it. We haven't gone through all the paperwork. We haven't done the work. It hasn't been approved by CMS. So in the language in that bill that kind of grandfathered in existing programs, we're not grandfathered in. So we're kind of right now stuck between a rock and a hard place. If we have this state law that passed that we're going to be working on, but now the federal piece could severely hinder our ability to implement the state piece.
Gotcha.
So we're still working through that. There was some language that, did kind of grandfather and adjusted the language. So it looked like maybe Idaho could get in, but then they did something on the other side then that still hurts Idaho. And so we're still trying to wade through that. And I wouldn't be surprised if we don't see, I think a lot of people now are starting to read what's in the bill and understand what's in the bill and how it's going to impact their state or their industry. I wouldn't be surprised if, the remainder of this year we see some fixes.
Gotcha.
Or some adjustments. And we certainly hope if that happens, all we need is language that says, let us be on the same playing field as the other states.
Right.
Just, I understand you don't want to move forward, but we're one of the, we're stuck in the middle. We can't have the old program that we used to use to offset some of those losses because we're moving into managed care, but we don't get to access the new program that's available for states that use managed care. So Idaho really is in a unique position in kind of getting stuck between what the feds and the state are doing. And so that is going to be a big challenge for us in the coming months and years.
I don't think anybody would accuse the federal government of making life easy for Idaho. There's that. Well, listen, Toni, is there anything else you kind of want to touch on? I know we've hit a bunch of things. Like I was not anticipating talking about this many different subjects, and we don't have to hit every single topic in one conversation. So is there anything you'd really like to hit here kind of at the end?
I've been traveling around the state a little bit over the last month and doing presentations to boards of trustees and folks like what happened during the legislative session. What does that mean for us? What's going on? And I typically always try to include something positive, and it's getting more and more difficult to do that. And I hate to come into a community and just be like
doom and gloom, and that's it.
Toni, also known as Debbie Downer, is going to come give us an update on issues. But I do have to at least give some positive note. The one great thing about traveling around the state and going to these little hospitals is it really just kind of reminds me what I do and why. And they are just doing amazing things in their communities, and the innovative things they're doing to continue to provide services as reimbursement just keeps getting ratcheted down or things become more complicated, or there's a new reporting requirement that somehow a legislature who says they don't like government bureaucracy continues to pass laws that create government bureaucracy. So that's always a challenge. But I just am so amazed at what they're doing and how dedicated they are and how they're excited they are when they can do something well. I mean, the CEO of that little hospital, his level of excitement of getting an OBGYN recruited to Idaho was just palpable. I mean, he just was so excited.
Just glowing.
Yeah.
Just glowing.
Yeah. But then immediately
did he find another one?
Not yet.
Okay.
No.
Well,
and it's not going to be easy. It's not going to be easy. So I really want people to know how dedicated these folks are to providing care and how even with all of the challenges they face. And I mean, keep in mind, half of our little hospitals are operating on a less than 1% margin. Some of them are operating in the red. And so when these proposals come up, you're like, well, it's just 1%. Well, yeah, our margin doesn't reach 1%. So it's like death by, 1,000 cuts. So it's just the resiliency of these folks to say, okay, we got cut over here, but we're going to try to do this new program over here, or we're going to partner with another hospital to see if we can share a specialist that'll do 3 days a week here and 3 days a week in this other community. The partnerships, the just innovation is amazing still. And it still keeps me going. And I think Idaho can be really proud of all the providers they have around the state and how they're working together. I've never seen the level of collaboration in Idaho that I'm seeing right now. And I think, as much as I hate to even mention this word, but COVID had a lot of impacts on Idaho.
Yeah.
One silver lining was it brought our hospital community together to collaborate, to work together, to find ways to do things, and to just support each other when things get tough. And I'm still seeing the benefit of that in some parts of the state. So that is what I hope people will realize. We don't try to come on and always be complaining about something. But that's getting harder and harder. It really, it's just every time they turn around, they're getting hit with something. And
this legislative session in particular seemed to be one of just, body blow after body blow.
Just the volume.
Yeah.
It's that, and that is something relatively new to Idaho. We didn't used to have this kind of volume. Maybe we had this much legislation get introduced, but it would get introduced and, then you'd go to the chairman and ask for a hearing, and the chairman would say, well, have you talked to the entity that's being impacted by this? Right. If you said no, the chairman would say, well, okay, well, come back to me once you've talked to the stakeholders.
Right.
And got their input. And now we're just seeing almost everything gets a hearing. And the hearings are not as in-depth as they used to be. We used to have pretty long hearings, and you could get into the depth of pieces of legislation.
Right, the problems.
Now it's almost always you have a 2-minute limit on your testimony. And that doesn't even allow you to get in. I had a piece of legislation this year I testified on. It was in a committee that had never heard of the issue. It was a brand new issue to them. It impacted hospitals primarily. I literally was told, Miss Lawson, if you could limit your testimony to 1 minute, we would appreciate it.
What happened with the issue?
The bill passed. And we are now still trying to figure out how we're going to implement it.
Oh my gosh,
some of the
60
issues.
seconds.
So this is the kind of stuff that we used to have, we didn't.
Robust discussions, at least open
didn't
discussions.
Always, maybe I didn't, we weren't always successful in whatever our position was for or against something, but you felt like you got a good chance to give your argument and explain things. And, you try to have those meetings in private and educate folks on the issue, but the volume was just so great that you didn't have time to even have private conversations with the committee to help them understand, here's something you might not have considered that this language does that I don't think is the intent, but it's in there. We were just go, 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 go. And I think right now we are not seeing the kind of in-depth consideration of public policy that we have in the past.
Well, you are always welcome here, and you can have more than 60 seconds.
People might want to limit you to 60 seconds after they hear what I have to say.
Toni, thanks for coming on. I really appreciate it. These are complex issues. And again, the more I learn about the medical industry and the hospital industry, it's like, wow, man, I'm amazed it works at all. So thank you for advocating for them and helping them. Thanks. And thanks for what you do for us.
Thanks for the invitation. I think there will be a lot more complicated things coming. So I imagine healthcare will continue to be a topic that you deal with.
I can't wait. It's great. Thanks for coming on.
Thank you.